Good afternoon, everybody. It is Friday and the 9th of June. You're here at Lunch and Learn. Aaron is getting everybody unmuted. Dr. Stewart is on vacation through the end of next week. And today we just have, I think, Aaron and I think Judy's off and Veronica's got tied up with office things. So today we're going to be talking about, there was a question that was asked by somebody, and that person is not here. And so, at least as far as I can see right now, is not here. So we're sort of just going to talk about, let you ask questions about software in general, and see how that goes. We didn't have a particular topic planned other than maybe mentioning some things about coherence, because that was a question someone asked. And again, about the activation scores. So let's wait and see if we're going to wait a minute and then let you all speak up and see if there's particular topics about the software that you would like to have a little bit cleaner explanation about. We're not getting a whole lot of response, Aaron. So I think we can just maybe just go into talk a bit about the activation scores, at least, since people sometimes have questions about that. And that did come up. So we're starting a session. I'll let you go ahead and talk.
So yeah, we'll start off talking about activation here, since we're already starting to get some scores in here. So I guess first of all, what is activation? What are we even looking at? What is that telling us? So in Newmind's clinical software, activation is the ratio of slow to fast wave frequencies in the brain. Proxy measure of brain activation. Lower values indicate higher levels of activation. Okay, so let's just break that down into human talk. So our ranges here on activation, we're looking for our clients to ideally be within a range of 2 to 3. That's the sweet spot. Now, if they get above 3 or below 2, it's kind of awkward. It took my brain a second to wrap its head around this. But if your numbers are above 3, that's actually indicating that the brain is in a state of under arousal. Okay, so that would be, if we were looking at trend lines, a number above 3 might be having delta and theta, sitting up quite high. So that would be like if you're training, let's say, a child with attention and focus issues. When we first start, we generally see that delta and theta is quite high. We've got beta down, generally in a normal range. So the fact that there is so much excessive delta and theta comparatively to beta, that is going to put this number generally above 3, and that's going to be a state of underarousal. So that's kind of at the starting phases of training somebody, when your trend lines, when you don't have that compression, and there's a ton of space between the slow waves and then delta or alpha and betas. Now on the opposite side, if we get numbers below 2, then that's a brain in the state of overarousal. So that would generally be, you might have fairly normal range of delta and theta, but the beta is running higher than average. So the amount of space that we would see in the trend graph between delta and theta and beta, is going to be pretty narrow. Now, in a lot of cases, if we're dropping below 2, and definitely if you're down in like the 1 range, that could just be from artifact. Since Dr. Suter's been on vacation, quite a few of these webinars, we've been really kind of talking about artifact, because it plays a role, in daily sessions. I see screenshots, or go into somebody's software and look, and I see it more than I would like to, where high betas running, upwards of 10 plus microvolts. So if you're seeing really low activation numbers, I wouldn't just jump to a conclusion that, oh, there's way more beta here than what I should have. I would be looking at EMG numbers first before I made any decision on, is this activation number truthful? Is it accurate? Or are we getting a false number here due to EMG? So we can see in this particular recording, EMG here is almost nothing. I mean, this is lower than what we would expect to see on somebody. I mean, average, if somebody's relaxed, EMG is generally running, 1.5, 2, 2.5. Now, of course, our EMG numbers aren't going to turn red, indicating an issue until they get around 9 or 10, which is, in my book, that's, even a 7 is way higher than what I want to see. When I do trainings on people, if I see them getting up around a 5 on EMG, I'm generally going to, remind them to stay relaxed, maybe drop their jaw. If they are watching a movie, I'm going to be paying attention if they're emoting. And hopefully I didn't make the mistake of caving in and letting them watch a movie that was inappropriate, causing them to emote more during the session. But ideally, we want to see that activation between 2 and 3. And again, if it's down below 2, pay attention to your EMG, look at your trend lines. You can follow average amplitude, however you want to do that. But keep in mind that, if we're training somebody eyes open, normal distribution of power for our beta frequencies is 5 to 6 microvolts plus or minus 2. So if you're seeing, high beta, especially above 8, you've got a problem, because that range that I just gave for beta, the 5 to 6 microvolts plus or minus 2, I mean, that encompasses the entire range of our normative database. So that would be from age 5 to age 90, and that's a pretty small little window. And of course, we would expect the kiddos that we're training are going to be generally running higher than average power. So out of that 5 to 6 plus or minus 2, the young kids, we would expect them to have a higher than average amplitude. Whereas if we were training somebody in their 70s, 80s, 90s, we would expect them to be at the lower end of that range. So if they're running really high beta, more than likely it's from tension. Now we can also look at activation on its own. So we can see in the graphs here, our development team has marked out that sweet spot zone. So we see the 2 to 3. So you can always come here and just watch the trend of activation as you train them. Now, as far as paying a lot of attention to activation, that would, for me, it's dependent on the protocols I'm using. So let's just say we're running an asymmetry protocol. We're just working on alpha and beta asymmetry. Delta and theta aren't even in the mix. I'm not going to really be paying too much attention to activation as far as looking at it from a standpoint of, is my client improving? Since I'm not training any delta and theta down, asymmetry protocol really isn't going to have any impact on activation. Now, yes, you are bringing beta up on the left, so we might see, a mild impact in the activation scores, but that would really just be in channel 1. As far as channel 2 goes, we're actually bringing beta down and like alpha up. So that's really not going to have any impact on activation. Where the activation numbers are going to be I'm going to be using them more or during the entire session would be in the case if I'm running a protocol 1, a 2, a 4. You might have realized I didn't mention protocol 3. That is a protocol I'm just personally not a fan of. And I will just say that now because it comes up on lunch and learns, and it has for the better part of 10 years of when we're training somebody who has an issue with those, just keep on this subject of activation. And so we've got somebody with a lot of excessive delta and theta. You know, our database is going to recommend protocols based off statistically what's the worst. You know, and I think almost everybody on this webinar today would agree that, you know, in a lot of cases when we look, especially at an eyes open map, that's a common thing we see, you know, is a lot of excessive delta and theta and alpha, with generally, you know, sometimes normal to low beta. You know, so statistically, when the database looks at that map, it's looking to say what protocol would be the best to use here to get the quickest results. And so it is going to recommend protocol 3, but for those of you that aren't aware, protocol 3 is by far the most difficult protocol that's in the New Mind list. And the reason for that is that the protocol is designed to train delta, theta, and alpha down. So it's basically a squash protocol, or I would actually say more like a mini squash because it's not touching any of the betas or any of the betas. So whenever you're running a squash protocol, you're asking the brain to do a tremendous amount of work. We're asking it to reduce 3 out of the 4 major component bands, which some people can do. Don't get me wrong, saying that no one's going to respond to a protocol 3, but when cases have been reviewed on the lunch and learn, and there was one in particular I remember about 7 years ago, a clinic had done roughly 60 sessions on a kid. You know, the kid's map initially presented with a bunch of excessive delta, theta, and alpha. The database recommended protocol 3, and the clinic ran roughly around 60 sessions using protocol 3 in different locations. And, you know, the end outcome is post 60 session map, there was pretty much no change. In the end outcome, it was 2 factors that created this problem. The first factor was the child had food sensitivities that really hadn't been managed. And on top of that, they were running protocol 3. So, you know, because there was already issues with a food sensitivity, you know, we know that if somebody has a food sensitivity and they're eating that food, let's say like gluten or casein, that's going to cause inflammation of the gut. That's going to transfer to the brain. And now that inflammation is going to keep that delta and theta elevated. So that's one problem. Problem 2 was that they were using the most difficult protocol in the library. So for that reason, and you will hear Dr. Suter comment on this when we look at a map, when it gets to the protocols and what's recommended, if the database recommends protocol 3, generally what you will hear Dr. Suter say is, well, I might use a 2 or a 1, you know, or maybe even a 4. You know, so if you're using protocol 1, you're just targeting delta. Protocol 2, you're just targeting theta. If you're in protocol 4, you're going to target delta and theta. So keep that in mind. If you have somebody that you're training for focus, attention issues, working memory, you know, anything that's going to be controlled by having or symptoms that are going to be caused from excessive delta and theta. If you decide to run that protocol 3, keep in mind that delta and theta should have roughly a 1 to 3 microvolt change, within the first at least 3 to 5 sessions, which also means if their brain is responding to a protocol 3, you should see a drop in the activation numbers. So that's another way of kind of tracking to see if the protocol you picked for that client is actually doing the job that you want it to do. It's really
I'll
kind of
throw
just
in another piece of just useful information. If you have a map that has those elevated delta, theta, and alpha waves, then let's just take C3, C4 as an example. And you notice on the map that the C3, C4, and delta is yellow. The C3, C4, and theta is yellow, but the C3, C4, and alpha is red. Then I would say just go ahead to protocol 4, because the alpha is not as bad as the delta and the theta, and by targeting those two slow waves, delta and theta, that will also help pull that alpha down even though you're not targeting it. So that's another sort of way to think about using that protocol if you have to, because I've used it several times, but I mean, I'm looking at a map where everything is yellow, you know. And then if you notice that the alpha isn't terribly high, then go to protocol 4, and just use the delta and theta. And I want to also comment, a while back you were talking about the emotional status and activation scores. It's one of the reasons that I think we all harp on trying to show people educational materials. I went to go help a clinic set up, their equipment a while back, and they were letting people pick what they wanted to pick on things like Netflix and their own streaming. So keep in mind, if you're looking at artifact affecting, your activation scores, sitting there watching a comedy and laughing is going to give you some definite artifact.
Yes.
And we have to think about the other side. You were talking about like an emotional. If you're watching something that's emotional, somebody's doesn't maybe understand why they get emotional at times, but if they had a trauma background, you could just see a single scene in a movie or whatever you're watching that could trigger a trauma memory, and there you go. Now they start tensing up because it triggered that memory. So it's one of the reasons we're always encouraging people just use educational materials whenever possible. And I would never encourage you to let somebody select what they want to watch. I would give them choices of things within maybe YouTube. If you want to, go and do some research and find educational things in YouTube or other streaming channels, if you have a Roku stick or something like that, Netflix or whatever, there's lots of educational materials. But once you start getting into comedies or dramas or thrillers or things that create emotion, whether it's joy or sadness or fear, you're going to get more of that response that Aaron was talking about. Just some thoughts.
Yeah, I agree with you there, Rob. And Rob, you had mentioned, I had talked about the moving art series on Netflix, and you brought up Relax TV.
Yeah.
I did a little searching, and actually, they're on YouTube now. So
Oh,
they're all
good.
available at no cost. So you can check that out for your clients. It's they're moving art and the Relax TV are very similar. Moving art's more video. I think the Relax TV is more still images.
Yes.
But ideally, great content to use.
Yeah.
And I can attest to this because I kind of, with my training my dad since he had a stroke, I got to a point because he was arguing about watching nature documentaries, and so I finally said, okay, what do you want to watch? And he picked some vampire show. And I can tell you, it was anytime if I let him choose what he wants to watch. As I'm training him, I've used TeamViewer, so he's at one side of the house, I'm on the other in my office, and if he watches what he wants, I can tell you, I'm looking at ENG numbers of 10 to 15, because he's watching these inappropriate content, and then, if I switch over to something like moving art, um, he'll stay in the 2 to 3 range on the
Yeah.
EMG. So I mean, it's really important, everyone, that you don't cave in with your clients. The comment I used to make to clients, and the way I've done it, like with Netflix, is I spent half an hour to an hour going through documentaries and content that I knew would be appropriate. And in Netflix, it gives you the option in there when you view something, and it says add to my list. So you
Hmm.
can just keep doing that. And then when your clients come in, you can just have that my list screen up with stuff that you've already scanned that you know is appropriate, and tell them this is what you have to choose from.
Yeah.
Now, Rob,
Good
you
idea.
probably agree. You get the people every once in a while that just want to argue with you.
Hmm.
Um, and what I would tell them is, I understand maybe this isn't what you would choose to watch at home, but this is a therapy,
This is therapy.
and
This is not entertainment.
yes, this is not the movie theater. We don't have popcorn and sodas and all that. You're here to get help. Um, and I definitely remember Dr. Suter years ago talking about a client that came in, uh, and she brought a DVD with her, and she insisted that that's what she was going to watch during her session. And I know Dr. Suter had mentioned he tried explaining to her why that wouldn't be a good choice, and she kept pressing him. So finally, he just said, "Fine," threw his hands up, said, "That's what you want to watch, so be it." And 5 sessions later, the lady made a comment that she was upset because she hadn't felt any shift in any of her symptoms. And Dr. Suter referenced back to the comment they had initially about the content she wanted to watch, and convinced her to try something more appropriate. And lo and behold, within just a few sessions later, she came in and commented that she was already feeling a shift in her symptoms. So it just kind of
Yep.
goes, to support, kind of what Rob and I are talking about, that, content is highly important. So, think about that with some of your clients. What kind of content you let them watch? Because I think, if my memory serves me correct, Rob, I think Dr. Suter kind of used more self-help style videos. What is anxiety? What is depression?
Yeah, yeah. There's several that he had mentioned, and remind me to talk about posture quickly too, in terms of activation. Instead of another example. But he had researched a bunch of things. He's the one that told me about Relax TV years and years and years ago. And then another video came out called This Emotional Self. So that's could be helpful and for people who are trying to understand their emotions. And again, you're sort of educating them during the time they're in the chair training. So things that are health related that are not going to cause they're just educational versus trying to create something where I wouldn't be showing people with cancer films about cancer survival. That's not what we're talking about, but something that just helps them better understand the condition they're working with from an educational standpoint and gets them thinking versus emoting. And another thing about the artifact again and activation scores, and this is a very unusual case, but it could happen to anybody. I have a kid, Aaron, he comes in, he's probably 6 or 7, he's sitting in the chair, and I'm training him at FP1 and FP2. Now, I expect there to be some artifact there, because you're training around the eyes and you have eye movement and people frowning or blinking or whatever. But this kid had artifact off the chart. And so I called the mom in because I'm watching this kid and trying to watch him and watch the screen and what he's watching. And I asked mom to come in and sit down next to me and just keep an eye on him and tell me, do you see him moving? This kid is sitting absolutely perfectly still. He is not moving a muscle. And I've got this really high, EMG going on at FP1 and FP2. And so I said, could you do me a favor? I said, there's something going on with a bunch of muscle tension in his forehead. Can you take him maybe to a physical therapist and get something evaluated, because that's just really unusual. He says, oh yeah, I've got a friend who's a physical therapist. So she takes her kid to the friend and comes back the next week, and she goes, it was his posture, the way he sat, even though he was sitting still, the way he sat created muscle tension going all the way up his back, up his neck, over the top of his scalp, right to his forehead. So sometimes we may need to look at other resources to determine if you're getting really excessively high, activation scores or artifact, to see what's going on. And it could just be that it's that person's posture, and they sit still and you're scratching your head and you just can't figure it out. So just another thing to think about.
Yeah, it's a good thing you brought that up. Yeah, I can pull back the way back machine. I was licensed massage therapist for years, had my own private practice. Uh, and one of the modalities that I learned years ago, they call it anatomy trains, is the training. Um, and, it's all about how our connective tissue is all interconnected. There was a case of a lady who was having severe neck pain,
Mm,
to the point where it was starting to cause, chronic headaches. And the therapist that was working with her um, was, specifically doing craniosacral work, neck work, trying to release this issue. And they were about 4 sessions in, and the lady just out of the blue makes a comment about, I'm really happy that my toes stopped hurting. And come to find out, she had stubbed her toe really bad, uh, like 3 to 4 weeks prior. Probably broke it by the sounds of it, as long as it hurt. And the therapist that was working with her knew anatomy trains, had taken the course. And so she switched. She stopped working on the neck and she went down and worked on the feet. And within 1 to 2 sessions, the neck pain went away.
mm,
So it's just this whole interconnection. And um, so, yeah, I definitely see, Rob, where
yeah.
that posture would do that. And I can't even tell you how many calls I've gotten on the tech line of just that situation of, I'm looking at them, or a clinic will say, hey, can you take a look at this and tell me what's going on? It's like, well, you've definitely got a lot of artifact, and then the comment back is, but I watch them and they sit so still, they don't move and they're not laughing, they're not making expressions, but it could be a case like that. I've also, um, on the EMG ones, uh, I was doing a map training with a new clinic. The doctor had her young son there as the guinea pig. And as we were going through testing locations, we got to T3, T4, and it was just straight artifact. You could see it was definitely muscle tension in the waveform. And I kept asking, the kid, drop your jaw, relax. Come to find out, his jaw was actually relaxed, but he was biting the inside of his lip in the front. Just,
Hmm.
it was an unconscious thing. And so it took us a good 5 minutes, of kind of trying to think what could be causing this. And then the kid finally said, oh, I was unconsciously biting my lip in the front. I said, well, stop doing that. As soon as the kid stopped biting his lip, everything settled out, artifact went away, and we were able to continue. So just little things like that. There was talking about kids, of keep in mind the chairs you have,
Yep.
because I've seen where training a little kid and their feet aren't touching the floor, and the kid will start swinging his feet a little bit, and that transfers up the body, and you'll pick up EMG for that. So, for those of you that work with a lot of kids, if you don't have a footstool for them, I highly suggest getting something, so they can, all their appendages are firmly planted. on solid ground somewhere, on armrests, footstools, because that's going to go a long way in your client's training.
Yeah, absolutely. You
So,
know, Richard's talked about, you know, speaking of just those subtle movements, he's talked about when you're doing a brain map, if somebody were tapping their toe, it can show
mhm,
up.
yep.
So it doesn't mean you have to be jumping up and down in your chair, clapping your hands.
Yeah, and I was actually shocked when I watched that presentation he did on Artifact, and I mean, I could see a foot swinging, but I never thought just a gentle toe tap would have done it. Um, and that's something. If somebody could be tapping their toe inside their shoe and you wouldn't even see it, um, or he showed another example of hair brushing against an ear clip. So it really goes to show how little movement it does take, to create a lot of excessive artifact. Um, so, one of the questions on activation that was posed in that email, was we're talking about um, like compression versus activation. So keep that in mind. We can't show compression right now because we're running a session, so we can't see the performance screen. But I guess to answer that part of that one question, in case she watches this later, say, yeah, your activation numbers are going to be quite high. If your client, if you're looking at the performance screen, let's say at the end of their first session, and you see that the compression line is high, where we know the compression and convergence should be as low as possible on that performance screen. And actually, well, here, let's do this. We'll save this since the protocol decided to end just at the right time, so we could look at that. So if you're training somebody, this compression line ideally should be super low. And compression is just looking at the spacing between all of our component bands. So back to kind of that example of somebody that we're training with memory, attention, focus problems, TBIs, for that matter, somebody with sleep issues where their lack of quality sleep has caused an excessive amount of, especially delta when they open their eyes. Their compression is going to be way off initially, which also means their activation numbers are going to be rather high. So if you've got delta and theta more up here and a huge space between, on the performance screen, what that's going to look like is this compression line is going to be way up here. So that's kind of for trackability purposes. You can watch that. As this compression line starts coming down, that means that we're squashing down delta and theta, which also means your activation numbers are going to drop. So, and just the opposite, the longer we train them, with, let's say, we'll stay with that protocol 4, we'll see the delta and theta drop, and as that does, we'll get the activation to drop. I kind of wanted to go back, just talking about coherence, because I know that was so one of the questions. I don't have a lot of clinical experience at all running the coherence protocols, but I have watched Rob Cobin's video. I've watched Dr. Suter's on this. And kind of one of the questions was, tracking the coherence as we train them, kind of looking at this coherence threshold, is one way of doing that. But we have to remember when we're running these 4-channel multi-covariant coherence protocols that this coherence threshold is looking at not only channel 1 and channel 2, which I've just got this set as F3, F4, but it's also looking at the coherence of P3, P4. So this threshold is a combination of the coherence between F3, F4, and P3, P4. Now, to know which site, maybe, if your coherence is elevated, it's running 60s, 70s, there's a way of actually looking at the coherence of these two sites independently of one another instead of just seeing it all mashed together on one threshold. Okay? And that's going to be in this z-score screens. Now, a lot of you that are new, especially the people that have gone through training with me, when we talk about these training screens, I generally make the comment that, to me, z-score screen on a standard 2-channel, 1-channel protocol doesn't really do me a lot of good. I can get more information by looking at the numbers at the bottom of the screens, looking at my average amplitude of my frequency bands, looking at the activation trends or looking at asymmetry trends. But when you're running these 4-channel coherence protocols, this z-score screen can be extremely helpful. Now, one thing I want to mention to everybody about these z-score screens, and this is something I just learned about 6 weeks ago from our developer, is that when you load up a training plan and you start training your client, the z-scores are not loaded up until you actually click on that option. So I just want to kind of say it now. You're going to get a delay in your screen when you click on z-scores. Your software is not broken. There's not a bug in it. It just has to load up. And depending on how fast and how powerful your computer is going to really determine how long that takes. And I can tell you there was a clinic we trained. They happened to put the software on an older computer that was not even close to the right specifications of what we recommend. And when I was training them, when we clicked on the z-score screen, the software just froze. And the only way I could get it running again was actually to shut the software off by forcing it closed and then reopening it. But every time we clicked on z-scores, it was just the computer couldn't handle the computations necessary. So it just froze. You guys saw mine's pretty responsive, but I run a pretty high power HP Omen desktop computer. It has probably 3 times the amount of power we recommend for this software. So mine switches really quick. So I just want to bring that up since I'm talking about using the z-score screen, that just know that if you get a delay, it's just because your computer doesn't have as much power as probably what it should. You could always add more RAM to it, and that can help out. So with that being
That's
said,
a good point too. Just to add to what you're saying is I have the HP Omen as well, and what we're talking, the HP Omen is a gaming computer, folks. And so gaming computers tend to have a lot more graphics power and all that to run all those graphics and everything when you're doing gaming. And that's why we're recommending something like a gaming computer if you go out and buy a new computer, or get more RAM until you do get a new computer, because that's what they do. And that's why his screen is so responsive.
yeah, and of course, Black Friday's coming up here in a few months. So for those of you, if you are running these protocols and you're noticing that your software is kind of lagging pretty hard, you can get some screaming deals on gaming laptops during Black Friday. So keep that in mind. If you're going to upgrade, do it then. So here we can see this protocol that I built is running a theta down for the coherence. Now, we were looking at this average kind of trend here of coherence running at 67. And again, that 67 is a combination of all 4 channels. But here we can see on the 2D heads in the z-score screen, what we're looking at, if this is kind of confusing, what you're seeing is the locations here is amplitude of the signal. So this is microvolts of power. This is just like what you see when you're looking at a brain map. If the location dots are green, that means it's within a norm level. Light blue or red, that's 1 standard deviation above or below normal. And then the yellow and the dark blue is going to be 2 or more standard deviations above or below what the norm is. And then we see we have a line connecting those sites together. So this is basically like what we see when we look at the interconnectivity section of our client's maps. And the line is indicating hyper, hypo, or normal coherence. So as this has been playing through, kind of the trend that I've been seeing on average is that the coherence between P3, P4 on average has been running hyper. So we've had a red line there a good majority of the time. And the coherence for theta up at F3, F4 on average has actually been running a little on the low side or hypo. So this is just one way for you to really kind of see what's going on with the coherence. And Dr. Suter brought this up in his video discussing this protocol. It was recorded about 3 years ago. And the one thing that he mentioned was just the fact of how rapidly coherence changes and moves around comparatively to the amplitude of our signals. So coherence is going to be rapidly changing. That's what we've seen here. If you guys have been watching these lines, P3, P4 has been going from hypo or hyper to hypo, back to hyper, back to hypo. So we are seeing a lot of rapid changes. And then also for trackability, you do have a single trend line for coherence. So you guys can be following that as well, to see, if this protocol is actually affecting the coherence over time. So just kind of different ways of kind of utilizing your software to look for changes in your clients. I will just mention on this screen, this is the bells and whistles screen. You'll notice on the 3D, we don't have an option to look at coherence. We can look at power levels, like we would see on a head map. But to me, this is the bells and whistles kind of screen that we put in. It's kind of cool to, show your clients, or if you're going to do a health fair, you can have this up on your screen and people go ooh and ah. The 2D heads, though, it's not as cool to look at, but it definitely gives us really all the information we need, training these coherence, using these coherence protocols, to see, what is the coherence between these sites. Any questions anybody has?
Hey, Aaron, I've got several questions.
Yeah.
Rob, what was the name of the video that you had said something about emotions?
Oh, your emotional self. It's a
Your emotional.
it's a series of DVDs. I think it's like got 2 or 3 DVDs to it. You can probably find it on Amazon.
Okay.
But just Google it and see if it's in Amazon versus somewhere else. And sometimes you can get those used and they're in great condition, save a little bit of money as well from Amazon.
Okay. I don't see it on Amazon, but I'll do a look on it online. And then Aaron, on when you're talking about things that clients are watching, how does it affect them if what we select for them is something that they really are not enjoying? Does that have any effect on their session?
Yeah, it can. It's because if you think about it, if somebody's kind of disgusted, they're potentially going to be picking up some tension through the face. So yeah, it's a fine line of kind of finding content that is appropriate but also content that's going to keep our client engaged during the session and not leave them feeling in a state of disgust. You know, and years ago, Dr. Suter brought this up about operant conditioning, where you actually have positive and negative operant conditioning. You know, so that's the mechanism that neurofeedback is using to re-educate our clients' brain activity. Same mechanism that we used as a child to learn how to ride a bike. So, you know, kind of if we just take that riding a bike, you know, kind of the negative side would be, ow, I fell and scraped my elbow. The positive side of that, and what really sets in the learning process, is that positive operant conditioning. Hey, look, I learned how to ride a bike. How much fun is this? You know, kind of another way I used to explain that to clinics is, let's say, music. You know, you're like Rob, he does a lot of eyes closed with music. So let's say you've got a young client, let's say they're teenage years, and you've decided that your clients are going to listen to classical music only. You know, so the negative side of that would be a child sitting in the waiting room going, oh my God, I got to sit through another half hour of this god awful music. Now, in both, you know, versus, that would be the negative side. The positive would be if you actually had a client that loved classical music. You know, now they're sitting in the waiting room saying, I love coming here. You know, I get to sit and relax and listen to the most beautiful music. So that's our positive operant condition. Now, in both scenarios, your client's going to train, but they will always have better training using positive operant conditioning with them. You know, so yeah, it can have an effect. Not only it could cause artifact, but just them in a state of kind of disgust the whole time. Of, you know, God, I really don't want to listen to this, or I really don't want to watch this. You're not going to get as good of training. You know, it's kind of like what I had mentioned with the movie that Dr. Suter's client wanted to watch. You know, there was probably some change in her brain activity, but it wasn't until, you know, they found some appropriate content, you know, that they actually saw big changes, you know,
And
happening.
let me correct myself. I made a mistake. Whoever asked the question is called This Emotional Life. That's the name of the video series, and it is on Amazon, among other places. This Emotional Life is the name.
Okay,
Very
thanks,
good.
Rob.
You bet.
And then my last question is, when you're showing the slides here where you're talking about the different colors and what it means, if we do a map, an initial map, and then we do a follow-up map, and it goes like completely to the opposite and it looks way worse for the client, like how do we trust that we got a good map, or like should we redo it, or how do we explain to the client? Like sometimes I tell them, you know, it gets worse before it gets better kind of thing. Or you know, you move one part of the brain, it's going to move other parts. That whole conversation. But when you look at it in black and white, it just looks so much worse. I'm not sure when to trust the map and when to know when to remap.
So as far as trust, first of all, trusting the map, you know, if you're recording your QEGs in NewMind software and you've got the auto artifact turned on, then you can trust that map. Now, yes, you know, it's very common, especially post 20 sessions. So you've done the first map, you've ran roughly, let's say 20 sessions, and you remap them. 9 times out of 10, you know, if you do a map comparison and you look at the dials on that map comparison, in most cases, you're going to see that there's like about a 70% reorganization going on, you know, and only maybe a 20%, you know, or 30% normalization, you know, and that's just the brain moving things around and kind of cleaning shop before it can actually put stuff where it needs to be. I used to use an analogy, I picked it up from Dr. Suter. is you can think of neurofeedback like rearranging a room, redecorating a room that has no doors and no windows. So you're going to put in new carpet, new paint, so logic would dictate the only way we can do that is we're going to have to take everything and push it to one side of the room. And then maybe we pull up the carpet we can and we start laying the new carpet and we start getting those walls painted. And then, we get a couple pieces of furniture. We got a table lamp back there and a little table. Okay, so that's where we're at right about the end of 20 sessions.
Yeah, and I'll give you another variation of a way to explain to clients. What I used to do is talk about walking on a road, a paved road. Then you go to a packed gravel road. Then you go to a loose gravel road. Then you go to a packed sand road. Then you go to a loose sand road. So when you're walking on those different surfaces, it gets more difficult or less difficult. And when you're training the brain, we're having to go, through all those steps to get things back to normal again. If normal, say, is the normally paved road. So you're going to have some ups and downs, and that's very normal. The brain makes changes, and sometimes things change a little bit for the worse, as Aaron just explained, because we're shifting all that stuff around in the brain before it gets a little better. So sometimes I've used that example of walking on various types of surfaces. I've even used the example of mud. At the end you get in the mud, you're stuck, and it's hard to pull your feet out. So, but you'll get back to okay, but it does take time. So if you're seeing a map, the other thing I would add too is if you had a map with a lot of things you're trying to train down, remember, even though you're training 2 sites or 4 sites, the whole brain is responding to whatever sites you're using. And sometimes when you have a lot of high wave you're taking down, when you remap, you'll see that things have gone below the green, they're below normal. And that's typical as the brain, again, as Aaron's explaining, is rearranging itself and adjusting to all the changes being made with the neurofeedback, if that helps.
Yes, that helps a lot. Those analogies were perfect. Thank you so much.
You're welcome.
So the client came in, and after we finished with the map, told me that their fire alarms were going off in the middle of the night and that she didn't sleep well that night. And so then I was like, oh, I wonder if that's why your map looks so crazy, like from the last one. Could it be because she didn't have a good night's sleep, and she doesn't typically have sleep problems? And so then I started thinking, well, maybe I need to remap her. Can I trust this map that we did?
You can trust the map, but I would think there's the sleep, the really disturbed sleep could have affected if she was really tired, she's yawning, she's not thinking clearly. I mean, I try to, when I mentor people, explain that to them when I'm talking about people with poor sleep. I say, think of if you didn't have a photographic memory and you're in graduate school or college and you go through exam week, by the end of the week, because you're burning the candle at both ends, staying up late, studying, getting up early and studying, you're trashed. But over the weekend, you get back to normal and you're okay by that following Monday. But a person with poor sleep, it's like they stay like that Friday after exams. That's what it's like for them every single day of their lives.
Yeah, I would suggest remapping her, Charlene, just to be confident, because of that lack of sleep. And because there was I had a clinic that had this was Colorado-based clinic. They had a client who was using medicinal cannabis in small doses in the evening to help her sleep. Well, the clinic followed my instructions on brain map prep, which is no alcohol, no recreational drug consumption for 3 days. So they asked this woman to refrain from using the cannabis for 3 days before the map. Well, she shows up the day for the map, and she had slept about 4 to 5 hours in that 3 days. And the clinic called me and they said, "What should we do?" I said, "Tell her to go home, eat eat one of her gummies and go to bed. Get a couple good days of sleep and then reschedule her." And that's why we do have that the EEG and drug effects chart, is for situations like that. Because I would rather, have somebody on, a 10 milligram a night dose of cannabis to get a good night's sleep and do a map that way, knowing that I might see a little elevated alpha in that map due to the cannabis consumption. you know, but at least I know, you know, they've got a good night's sleep. I know the delta and theta I can trust now, you know, and then, you know, the protocols I get are going to be a lot more accurate than, you know, somebody that's, you know, in a state of exhaustion. So, and that's why we also always recommend mapping them, you know, in the mornings, you know, so we're not getting them at that sleepy part of the day after the circadian rhythms kicked in. You know, it's that way we're going to get the most accurate outcome we can get. All right, well, we are.
Thank you very much.
Yeah, you're
We're at
welcome,
the
sir.
top of the hour, actually a little bit over the hour.
Little bit.
So Monday we'll continue. We don't have any specific topics set for next week, but Aaron will be doing more training on software next week. So if you have particular areas or questions, like, you know, the session settings, that's a whole panel we could go through if you want. And you know, audio fading or whatever, then send them along ahead of time and we'll make sure to cover those. Otherwise, have a great weekend.